afternoon, everyone. Thank you for the kind words and the introduction, and thank you also for inviting me to speak today. The topic I'll be talking today is about the principles of diagnosis and treatment in skin of color. Now, it's quite a vast topic, so I'll be just skimming the surface. I have no conflicts of interest in this talk. Let's look at the background first. If you look at the topic of skin of color, it's been talked about and it's been written about for the last 20 to 25 years, but they're all anecdotal. In my opinion, it's become a lot more important since the Black Lives Matter movement. Just as a background, the Black Lives Movement was started in 2013. In 2012, a young teenager, unarmed teenager, was murdered by a Zimmerman, and he was acquitted of this in 2013, and that's when Black Lives Matter started. But it rose to as a global phenomenon really in 2020, when George Floyd died when he was under police custody. So that, I think, sparked the world's conscience. It was already reeling under the pandemic then. And when this came up too, I think quite a lot of other inequalities, particularly amongst those who have skin of color, including the medical literature, started coming up. Why is it so important? The important thing is that we are becoming a global village. Everybody is moving from place to place, and skin of color is becoming more prominent wherever you live. If you look at ethnic plurality, if the US Census in 1990, they had 76% of people who are white in skin color. By 2050, there'll be a minority, there'll be less than 50%. In the UK, Leicester already has more people of skin of color than those who have white skin, and Birmingham will be joining it soon in 2025. But if you look at the literature, there's very, very limited literature in skin of color. How do we define skin of color? Well, the definition we all use is the Fitzpatrick classification, but actually it's Fitzpatrick-Pathak classification. It was written by two people, one of whom was Pathak, who was an Indian photodermatologist. Now, we never hear of him. So is this academic prejudice? I guess we will never know. Along with my colleague, we presented a poster on Professor Pathak a couple of years ago, and in that we quoted one of Fitzpatrick's first publications on skin typing. And if you look at the article, he himself has written Fitzpatrick-Pathak skin typing system. So for some reason, the second word has just been airbrushed from our academic literature. What did they describe? When Fitzpatrick first described it, he actually had only 4 skin types, and it was all white skin. He added in 5 and 6 as an afterthought as Asian and Afro-Caribbean skin. He classified types, white skin into 4 types. And these are some young women whom I'm too old to recognize, but you can see roughly what kind of skin type they have. And skin type 1 is those with red hair and blonde hair who never tan. And skin type 4 is the Mediterranean type of skin where they always tan and never burn. And Asian skin is 5 and Afro-Caribbean skin is 6. But this is quite flawed because I see many Asians who could actually fit into skin type 3 or even skin type 4. So I guess we don't have a standardized system of skin typing, but for the time being, we could classify all skin of color as Fitzpatrick-Pathak skin type 5 and 6. I always believe that if you know the biology of a condition, if you know the reason why a condition occurs, then you'll know how to diagnose and treat it better. In fact, that's what I always teach my registrars. So let's look at the biology of the skin and how that's different in those who have colored skin and those who have white skin. The analogy I'd like to make is take 2 cars. You have a Toyota on the left and a Citroen on the right. They all look more or less the same. They probably have the same parts as well. But the way they function is slightly different. And that's the way it is for skin as well. We all have the same cells. We have the melanocytes, we have the epidermis, we have the dermis, but they work differently. It's like taking a Citroen car to a Toyota dealership and saying, oh, can you sort it out? They probably will know the basics, but for the intricate details, we probably need to know a little bit more specific about skin of color. We look at 3 different parts of the skin. We look at the stratum corneum, the melanocytes, and the dermis, see how they are different in the different skin types and what clinical applications they have. And in the end, I'll talk about 3 or 4 simple conditions which we say day to day and how the skin condition differs in skin of color. So the stratum corneum is the barrier. It's the barrier between the external world and the internal internal part of the body. And if you look at it, they used various methods, and they found that it is thinner in East Asians and it's thicker in blacks. And the way they did it was called tape stripping. They kept on stripping it with a tape till the barrier function was lost. There are some other articles which contradicted this, but generally they say that in the stratum corneum, it looks like it's a bit more robust in those who have dark skin, black skin. We also have to look at the structure of the stratum corneum. It's got the brick and mortar structure. So the bricks are the corneocytes and the mortar is the lipids which hold it together, including fatty acids and ceramides. And in studies, they found that the ceramides are less in those who have black skin. And there's also increased transepidermal water loss in blacks. And they found that there was slower desquamation in those who have black skin. What are the clinical applications here? The clinical applications is that those who have dark skin, particularly black skin, tend to have drier skin, tend to have more scaly skin. And because of this transepidermal elimination of fluids, they seem to have a high propensity for eczema as well. There was one article which suggested that they were less prone for irritant contact dermatitis because of the thicker stratum corneum, but that's a bit controversial again because that article was published in the 90s and it hasn't been replicated. What about the melanocytes? We all have the same, all of us in this room have the same number of melanocytes. But why is our skin looking different? And that's because the way how it behaves. The melanosomes which the melanocytes produce are different. They are non-aggregated, they're thinner, and they are larger in those who have dark skin. And those who have fairer skin, they are aggregated together and they're much smaller. The pigment is also different. Those who have dark skin make the brown-black pigment, which is called pheomelanin. And those who have fairer skin make a sort of reddish pigment, which is called pheomelanin. These are the common differences we note between white skin and those with skin of color. And the clinical applications here is that pigmentary changes are going to be a lot commoner in those who have skin of color. So if you have an inflammatory condition or even infections, as you'll see, pigmentation is a lot more common. You also have to see that inflammation can trigger off this hyperpigmentation. Many times you have inflammatory dermatoses and the patient comes to you because they are worried about the pigmentation, not the inflammatory dermatoses. Because of these melanosomes being more numerous and bigger, the pigmentation takes longer to go away from the skin. It takes a lot longer, even years sometimes. But there is a positive to this. There's less chance of skin cancer, particularly BCCs and SCCs, if you look at those with skin of color. And that's because the melanocytes protects them. Finally, we come to the dermis. The dermis tends to be thicker and more compact in those who have black skin. The collagen fibers are smaller, but they are more closely bound together. They have proteoglycans, which make it a lot thicker. That does have a clinical implication, which I'll mention. The fibroblasts are increased and they're more reactive, and they also produce less collagenase, so they're not broken down as quickly. There's one publication which said that the sebaceous glands were slightly more active in black skin, but again, that has not been replicated. The clinical implications are there is propensity for hypertrophic scarring. So if you do surgery or even after inflammatory conditions, you can get hypertrophic scarring, even keloidal scarring. And that's something to remember. You have to treat early. You don't want the inflammation to cause that kind of scarring, even in conditions as common as acne. Because of the organization of the collagen, you can also get less photoaging. So not only do the melanocytes protect those with skin of color, it's also the way the dermis is organized. That also makes those with skin of color age less than those who have fair skin. I'm going to now talk about 4 conditions. 2 of them are inflammatory, one of them is an infection, and one of them is a cancer. And let's see how it is different in skin of color compared to those with white skin. Atopic eczema, one of the commonest conditions we will see. If you look at it in those with skin of color, there is a higher incidence. They did a big study, a demographic study in the US, and they found that black children were twice as likely to develop atopic eczema compared to white skin. The other interesting feature is also the morphology of the eczema. There was a very good talk by Susan Taylor last year in the BAD, and she spoke about it. And I'm just going to mention a couple of morphologies as well, which you will see in those with skin of color, but not as commonly in those who have fair skin. Now, the reasons you get eczema more commonly is due to the structural changes I've already spoken about. I told you that there was less ceramide and cholesterol, and I told you that there was higher transepidermal water loss. And this results in an impaired barrier function and therefore an increased severity of atopic eczema. This, I think, can be translated to treatment because if we tell our patients that their skin does tend to be drier, It emphasizes the reason why they have to use moisturizers a lot more and perhaps a lot more frequently than those who have fairer skin. Let's look at a couple of morphological subtypes. This is called the follicular subtype. And one of the good clinical tips which Professor Taylor mentioned was sometimes you have to palpate the skin. Don't just look at it, it'll look macular. But when you touch it, it's just slightly papular. It also can have variable colors. It can be pigmented and it can be hypopigmented as well. Lichen nitidus or papular eczema is very similar, but it's not related to the hair follicles. It can be randomly anywhere. And particularly lichen nitidus is something which I've seen, particularly when I trained in India too. It's a lot commoner there, and probably there is a genetic predisposition to get those kinds of morphologies. It's more common in the trunk and extremities. With the management, there are certain pitfalls here. You don't see the erythema, the pigmentation covers the erythema, so you definitely try to underestimate the EZ score. So therefore, we undertreat people, or sometimes we don't even treat them because we can't see the erythema. So this is something which is important. I think we have to be a bit more aggressive in the way we treat those who have skin of color because we can't see the clinical findings as much as those who have white skin. Post-inflammatory pigmentation is also very prominent. I told you how reactive the melanocytes are, and therefore, the earlier we treat them, the less post-inflammatory pigmentation there will be. The other issue is also the way we treat them. If we use potent topical steroids, that's more likely to cause hypopigmentation. Now, that's a double whammy. You don't want to use anything too strong because that's going to cause the opposite. All the more reason why the earlier you treat them, the more you try using sort of preventative management like barrier creams, that's the better. There was a good article in the Royal College of Medicine recently which suggested that even medications are different because of the different genetic makeup. Methotrexate, for example, can cause alopecia more commonly in those who have black skin. And cyclosporin has a lower bioavailability, so you are due to give them a higher dose. So these are subtle things which we probably do need to be aware of because these are common conditions we see in our clinic all the time. Next, go on to another common condition, acne. We have to start really from the history here. Now, the first history point is the oils that are often applied on the scalp. I come from South India, and in South India, we use coconut oil to just put on the hair because it gives you a sheen to it. Now, those oils can clog the hair follicles or the pores and cause pomade acne. It's also there in those who have darker skin because they use these oils to fashion their hair. The other issue is also that those who have dark skin want to be fairer. Grass is always greener on the other side. White people want to have a tan, and those who have dark skin want to be fairer. So those who have dark skin using skin lightening treatment, they have steroids in it. That can cause acne as well. So these are questions we have to ask our patients. The other important factor is that polycystic ovarian syndrome is more frequent in South Asians, and the body habitus is different. You don't have to have a high BMI. You can be slim and you can still have polycystic ovarian syndrome in South Asians. So again, an important historical finding and perhaps something we have to look for in the management, which I'll be mentioning. The other issue is the clinical features. Comedones are generally thought to be non-inflammatory. But there was a big study in the US where they found that if they did biopsies of comedones in black skin, they actually found neutrophils. So comedones are actually inflammatory pathologies in black skin, and that can cause you pigmentation as well. If you look at those who have acne in Asian skin, they're actually more worried about the pigmentation than the acne itself. Many people will come and ask you, what can I do to remove the blemishes? They're not worried about the acne. They're more worried about the pigmentation. And the only way you can stop that is by early intervention. Keloidal scarring is also more common. Again, we've mentioned already about the fibroblasts. So the earlier you treat it, the less chance there is going to be keloidal scarring. What are the management things we have to take into consideration? As I mentioned, it has to be early and it has to be effective. It has to be quite aggressive. With the topical retinoids, you have to be careful which topical retinoid you use. Adapalene comes as a cream. It's also less irritant, so it works on two receptors, retinoic acid 2 and 6. So it is effective, and it may be better tolerated than gels, which are there in topical retinoids. Azelaic acid is also useful because it decreases pigmentation. So you can combine a topical retinoid with azelaic acid, and that will give you good outcome in those who have pigmentation. As I mentioned, I would treat people as early as possible. So early antibiotics if they have pustular lesions, early isotretinoin if they have nodular cystic lesions, And if there's a hormonal pattern, as I said, in South Asians, spironolactone may be a very good option too. So these are subtle management points which we may have to defer from those who have white skin. I thought I'll put an infection in as well, just to show you how different this itself, a simple infection, can look in those who have skin of color. And the example I've taken is pityriasis versicolor, tinea versicolor. This is what you would expect to find: hypopigmented macules coming together to form big patches, and some of them have that perforaceous scales. But this is what you could see. It could be more pigmented. And sometimes it is hard to make the diagnosis unless your eyes are trained to this or your mind is aware that there is pigmentation even in infections. This is called chromic tinea versicolor. So even in a condition as common as tinea versicolor, it can be hypopigmented, it can be hyperpigmented. And then you look at the risk factors. I did mention to you that sebaceous gland activity is more possibly in those of dark skin, and that may be one of the reasons. The application of coconut oil on the skin, which is again a very common practice in South India, that may be possible. And then high humidity, and we are all experiencing increasing, because of climate change, warmer weather. So it is going to be more common if you have people with skin of color here too. Finally, I'm going to talk about one cancer, which is squamous cell carcinoma. And the reason I've picked up squamous cell carcinoma is it's the commonest skin cancer in blacks and Asians. So it is not basal cell carcinoma, it is squamous cell carcinoma. 30 to 65% of skin cancers in blacks and in Asian Indians is squamous cell carcinoma. This compares to 15 to 25% in those who have white skin. The other interesting factor is that it is found mostly in sun-protected areas, in contradisting again to white skin, where it's found in sun-exposed areas. Up to 65% is found in sun-protected areas, and in one series in the US, 20% was found around the perianal area. So all very covered areas. So it brings into question, what is the importance of light with the etiology of squamous cell carcinoma in skin cancer? It probably isn't that important. What are the risk factors? It's different to those who have white skin. The risk factors for skin cancer and skin of color, and this is something I spoke about to some of trainees in the West Midlands and in North Wales as well, is that it is chronic scarring and chronic inflammation, which is much more important. So if you have a field of hidradenitis suppurativa and you get a non-healing area there, that could be a squamous cell carcinoma. Discoid lupus is also notorious. If you see a non-healing lesion within a plaque of discoid lupus, which has been long-standing, you have to have a very high suspicion of squamous cell carcinoma, because that is one of the etiological factors. It also tends to be more aggressive. The metastatic potential for squamous cell carcinoma in white skin is about 1 to 4%. If you look at the same squamous cell carcinoma occurring on a background of discoid lupus, it's 20 to 40%. So it's incredibly high. And unless you keep this in mind, your threshold for biopsy should be low in anybody who has a non-healing ulcer. This was from a review article, Perianal Hidradenitis Suppurativa, and you can clearly see a verrucous growth there, and that was an SCC. And in fact, one of my colleagues, Dalia, also, we both presented a paper on hidradenitis suppurativa showing verrucous carcinoma in the perianal area. He was a Portuguese gentleman. That was about 3 years ago. So the prognosis is poor. We don't diagnose it and we don't treat it as aggressively, and therefore it's more advanced. You delay the diagnosis, and therefore this metastatic potential of 20 to 40%, which really is completely unacceptable. And the reason we have this rate is because we don't know about it. So the more we know about these small differences in skin of color, the better the clinicians we can be. The take-home points I'd like to make really is that the biology of skin is important. If you know the biology of the skin, you can understand the differences between skin of color and in white skin. One of the commonest things you are going to see are these pigmentary changes, and it's there in inflammatory conditions, it's in infections, it's even in cancers, because even basal cell carcinomas tend to be pigmented more than 50% of the time compared to those who have white skin. The most important thing is that it should be early and effective treatment. You have to diagnose it early and you have to treat it aggressively. That's the only way you can prevent complications in skin of color. And unfortunately, it is still underrepresented in the medical curricula. I make it a point to teach my registrars on skin of color, and I'm sure it'll stand them in good stead for the future. And if you look at all over the country, I think this should be part of the discussion we should be having. We are now treating people of all skin types, and the only way we can become wholesome dermatologists is if we know how to treat people with skin of color as well. I'd like to end a quote from one of my teachers, Professor Tambaya. He said, "The eyes do not see what the mind does not know." So unless we know our deficiencies, we look out for what we don't know and try to learn more about it, we cannot become better dermatologists. Thank you.